Hi, welcome to this step-by-step guide on radio frequency ablation or RFA for varicose veins. This video is designed for providing an in-depth look at the procedures, including the indications, techniques, and post-procedure management. So let's begin. RFA is indicated for patients with symptomatic varicose veins, chronic venous insufficiency, venous ulcers, or cosmetic concerns. Contraindications include acute deep vein thrombosis, significant peripheral arterial disease, pregnancy, or any untreated infection in the area of the treatment. By following these 14 steps, you can ensure that no critical aspect of the procedure are overlooked. Step number 1. Preoperative workup. Preoperative evaluation include a thorough patient evaluation including a detailed history and physical examination, a detailed venous duplex ultrasound to assess reflex patterns, vein diameter, and anatomical variations. Baseline vascular assessment and patient education are crucial before proceeding with the RFA. Step number 2. Reverse Trendelenburg position. The patient is positioned in reverse Trendelenburg to optimize venous filling and better ultrasound visualization. Step number 3. Vein mapping. A duplex ultrasound is used to precisely identify the varicose veins, measure vein diameter, and mark the optimal entry point for the procedure. Position of the patient is supine. The limb is externally rotated, slightly abducted, and a slight flexion at the knee joint. Here you can notice the great saphenous vein between the two fascia, that is superficial and deep fascia. Here you can see the saphenofemoral junction. Here is the common femoral artery, femoral vein, great saphenous vein, and you can notice one small tributary is coming and joining the great saphenous vein, that is the superficial inferior epigastric vein, which is the last tributary of the great saphenous vein. Step number 4. Needle insertion. Under ultrasound guidance, an 18-gauge needle is inserted into the affected vein, typically below knee, or you can insert it in the lower thigh, which depends upon the tortuosity of the vein. You can use inline approach or out-of-plane approach, depends upon your convenience. Here I am using an out-of-plane approach. Now you can see the needle tip is within the lumen, and this is classically known as bullseye appearance. Step number 5. Guide wire insertion. Once you confirm the venous return through the needle, a flexible J-tip guide wire is advanced through the needle into the vein to serve as a pathway for catheter placement. If the guide wire is properly within the lumen, the wire is freely advanced, there won't be any resistance. Step number 6. Skin stab incision. Using a number 11 blade, a small incision is made at the needle insertion point to facilitate the sheath insertion. Step number 7. Sheath insertion. A sheath, which is a thin hollow tube, is inserted over the guide wire, creating a stable access point for the radio frequency catheter. And you can confirm the catheter placement is within the lumen by using an ultrasound. Here you can see a nice free flow of blood, and you flush the catheter with the normal saline. Step number 8. Catheter placement. The radio frequency catheter is carefully advanced through the sheath up to the saphenofemoral junction. This is a 6 French catheter which has a natural curve, which is very helpful to negotiate through the veins. Here we are using Medtronic RFA machine, and it has a 7.5 cm heating coil at the tip. Then you negotiate the catheter all the way through great saphenous vein till 2 cm away from saphenofemoral junction, which is confirmed by using an ultrasound. Here you can see the tip of the catheter, which is pulled back 2 cm away from the great saphenous junction. Step number 9. Tumescent injection. Tumescent is injected around the vein to protect the surrounding tissue from thermal injury during ablation, provide pain control, and enhance the vein collapse. Here is the needle, which is just above the vein wall, and the tumescent is injected, and you can see the tumescent is spreading around the vein. Step number 10. Trendelenburg position. The patient may be positioned into the Trendelenburg position to further aid vein emptying, which improve contact between the catheter and the vein wall. Step number 11. Confirm catheter tip location. The catheter tip position is confirmed under ultrasound cadence, ensuring it is at least 2 cm distal to the saphenofemoral junction before energy delivery. Step number 12. Ablation of the vein. Radiofrequency energy is applied segmentally. The catheter is slowly withdrawn to ensure complete ablation. Once you see the warning signs over the catheter, you should pull the sheath, otherwise you will burn the sheath. Step number 13. Tackling the leg varicosities. If necessary, additional procedures such as USG guided form sclerotherapy, microphlebectomy or hook phlebectomy may be performed to treat residual superficial varicosities. Step number 14. Post-procedure care. After RFA, immediate ambulation is encouraged to reduce the risk of developing DVT. Patients are advised to wear compression stockings for 1 to 2 weeks. Post-procedure ultrasound is performed within 7 days to assess the vein closure and rule out the complications such as non-occlusion, thrombus extension, or endovenous heat-induced thrombosis. So, radiofrequency ablation is safe and effective technique for treating varicose veins. With the proper patient selection and procedural technique, you can achieve excellent clinical results. Thank you so much for watching.